Hello, everyone. Welcome back to the Surfside Recovery Podcast. My name is Brian Licata, and we just wanted to let you guys know that if you or anyone is struggling with addiction, to please reach out to Surfside. You can give us a call at 609-709-4205 or visit us at surfside.org and all of our social media platforms.
Hello, everyone, and good morning. Welcome back to the Surfside Recovery Podcast. My name is Brian Licata, and we have Alyssa here again this morning. Thankfully, we were just talking about before the show, Ian has been replaced. He's never going to be on a podcast ever again. He's done. He's done. He said Alyssa's doing it last week. He's doing it this week, and now he's just here no more. But we have a very special guest to introduce this morning, Dr. Gina. I've never met you until right now, so Alyssa has gratefully introduced us, and I'd love to get to know you a little bit. So how are you this morning?
Good. Thanks, Brian.
Okay, so for those who don't know, we've got Dr. Gina Innocente on the podcast. She is a clinician. She has her master's and doctorate in social work. She's based down here in our South Jersey region in Summers Point. She's got a really solid private practice. So, Gina, I want you to introduce yourself. Tell people just a little bit about you so they know who you are and why we should care that you're here today.
Oh, okay. I don't really know, why I'm here, but you invited me and I decided to show up because, hey, I have an ego,
What else do you have to do this?
I'm Gina Innocente. I have a private practice in Summers Point, like Alyssa said. I graduated in 1997 with my master's, and I got my doctorate in 2015. What else? I did a lot of inpatient psych work, substance abuse work, outpatient work, and then I started a practice, a really small practice, while I was working in other jobs. And I guess I went full-time private practice maybe about, how many years ago? Maybe 10, 12, 15 years ago. I don't know. What is it, 2000? Oh yeah, I guess 15 years. I'm old. I'm getting really old now. So I have a practice here with lots of associates. Most of us have our own private practices, but there are a few people who I work with and supervise. And I do a lot of trauma work and family therapy, couples work, individual therapy. I run a group with adolescents and keep it rolling, keep it interesting. So
Sweet. Okay, so I just feel like I have to say this because I tell everybody every time I talk about Gina, but she got her doctorate from Penn, so she is my Ivy League friend.
Wow. Very cool. Oh, there it is.
I paid a lot of money.
I always just feel like every time
$1,000 picture, my $100,000 picture.
Depending who I talk to, she's a colleague with a degree from Penn or my friend with a degree from Penn. Okay, so what I was thinking, I'd like to hear you talk a little bit about is, we've talked before about like theoretical frameworks and all this stuff that other clinicians know is important, but like the average family wouldn't know. So when a family or a person is looking for therapy, like what are those questions that someone should be asking their therapist, and kind of like what makes you qualified to see people? Can you talk about like what supervision is and why you think that's important, all that stuff?
Absolutely.
You just asked her a lot of questions at once.
I know. I'm like, keep track, and I think I'm like early perimenopausal, so my memory span, it's like I have to write notes down. So we'll just go in that order.
I'll interrupt you if I think you forgot.
Please do. So theoretical orientation, I think one of the issues with therapy today, and when I came into school, I had applied to Rutgers, and it was a clinical program, and when I applied, and then that fall, when we started, it became generalist practice, which meant social work has always been this war between, are we in the trenches working for, the oppressed and advocating, or are we therapists? And it's been this huge divide, so they took social work and decided to make it both, And it was like, you can't really be trained, in both in any kind of adequate way. And I think the LPC came sort of and evolved out of that. But that had its own issues early on. So anyway, I think there was this huge change just in the profession. And then managed care came into the picture, wanting like quick results. Hospitalizations that used to be a month or two became 3 or 4 days. And so everything changed. And out of that evolved this idea of cognitive behavioral therapy, because it was measurable. And it sort of became the way we just frame things. We were still doing, the work we used to do, but we would sort of document it in this CBT, cognitive behavioral therapy way. But then schools gradually started just training in that, and not that CBT wasn't valuable, but it sort of became this like BS way of saying what we were doing, and then it became this real thing. And, I really laughed at it for many years until I really started studying it and advanced. And in the last probably 5 years, I value it a lot more. But it really changed the profession, and things started getting more geared toward, symptom management and things like that. So what you have is, I think, a generation of therapists now who, if you look like on their Psychology Today profiles, it's like, what are your specialties? OCD, depression, anxiety, personality disorders, substance abuse, dissociative disorders, like trauma, this, that, like the list, like 15 things, like things that some of them I wouldn't still touch, but things I certainly couldn't possibly be a specialist in, especially early on in my career. And then in terms of theoretical orientation, I think, the field started describing themselves as eclectic. We studied, like each week a new theory, and that was it. You graduate and that's it. And then you come out of school and it's like, well, what do I do? I remember my first job, like I have no idea what to do, even though I had an internship. And then because the profession became flooded, we didn't have enough internships, so people weren't really getting the internships they needed. So I was very fortunate because my first real job was in an inpatient dual diagnosis unit, and I was surrounded by therapists who were like old school, and so I found that supervision was this like remarkable way to learn and to figure out what, I feel like your theory finds you, but once again, if you see, people's profiles or what they'll say, what do you specialize in? And they'll say, CBT, EMDR, relational theory, psychoanalytic theory, and you can't possibly study all of those theories. You have to have like one base, and then you incorporate other things, certainly. But I think people have a really tough time knowing one theory very, very well, because it doesn't, again, mean you can't apply other theories, but someone said to me once, like, when in doubt, you fall back on your theoretical orientation. When you're stuck, you go back to like, okay, let's go back to attachment theory. Let's go back to relational theory. Let's go back to the basic and say, how can I understand this client in this context?
Well, I was just going on Psychology Today, and I think I want to find a therapist. What does all that mean for me? Like, what is that for someone who knows nothing about mental health or what to look for?
Right. So it's hard because Psychology Today, like all the profiles pretty much look the same, in terms of what everybody says. I think the best way is to, I'm shocked, if someone calls and they get my office manager and just schedule an appointment without talking to me, or I've had people now, send an email or a text message even, I'd like to schedule an appointment. And it used to be, again, if someone contacted you, like if they looked you up in the phone book or something and contacted you, that told you something about them. Like, what? You you must be really isolated, if you found me without someone else. But so
how did you usually get people? Would it be like a reference thing? Like word of mouth?
Yeah.
Oh, okay.
And that's the primary way I get people now. So
right.
I think, the first thing is to call, right? And to ask a couple of questions. Number one, how long have you been doing this? And even that is vague, because how long have you been doing this is well, do I count my internship hours? Do I
Right.
count? And, you have to be in the field, a couple of years before you get licensed. So I think the more specific question is, how long have you been licensed? You know,
Hmm.
and then what exactly are your credentials? And you want someone who has at least, obviously, a master's degree in either social work or counseling or addiction counseling, or I mean, there are a number of them that you can find. Or even better, a PhD or a doctorate, because again, because of the lack of training that we're getting in our master's program, I think a doctorate is much better now. I mean, I think a doctorate is actually what people used to get in their master's programs. But even with that, you want to find out what kind of doctorate, because now there are so many like online, sort of, you know, PhD programs where they're like pseudo science degrees. I remember a friend years ago got a PhD in metaphysics, like it was like, and suddenly a year after graduation he has a PhD, and the psychologists in the office are like, "Are you kidding me?"
I
But
think I've told you before. I have a girlfriend who I've known for years who her mom had a doctorate. It was like, I think she was a doctor of nursing. And every time she would get in trouble at school, she'd be like, "Oh, call my mom, Mrs. So and so." So they'd call her mom and they'd say, "Oh, is this Mrs. So and so?" And her mom would go, "It's doctor," and hang up the phone. She like knew that her mom would hang up on the school when they were calling to like
awesome, I love
send her.
That's
It was,
hysterical.
it was hysterical.
it.
I think that's why I'm so adamant that I call you like Dr. Gina.
It's so funny because my wife will always say to me, "Why couldn't you be an RD?" And I remember the first time she said it, I'm like, "What's an RD?" And she's like a real doctor, RD, like one that makes real money. I was like, oh.
Okay, so talk to me about like what you do when you supervise other clinicians, because I know that I've talked to folks who get supervision from you.
So
So
I'm a huge, believer in supervision. I mean, I've been doing this since I got licensed in '99, so 21 years, and I still do regular supervision, like paid supervision, at least once a month. But I think I lost money in my private practice the first few years because I had like one or two cases, and the whole point of them was to learn. I think I charged like $25, and paid $125 for supervision every week because it was so valuable. You don't know what you're doing. I mean, you really don't with just a master's degree and a year or two of experience. You have no idea what you're doing. The problem is, you think you know what you're doing. Like you really do. When I learned,
like, do you like sit with someone
yes,
and their
so
patient, or do they talk to you about their patient afterwards?
so early on before your license, supervision is like you'll actually sometimes do co-therapy. You and
Hmm.
another therapist will do it together, which I love to do. That's one of my favorite ways still that I can learn. If another therapist and I will sit together and work with a client. So yeah, that's one way, but mostly traditional supervision is it can be done in a group, but I like to do it one-on-one, and I like to, either do it with myself or with other people, especially therapists who have been doing it for a while, because you get into more advanced ideas. But you sit and you talk about your clients, and you talk about what's going on with them. You present a case and you talk about how to help them, what goes on in the therapeutic relationship. I mean, that's one of the primary things that you can deal with in therapy is, what you're feeling about the client, what they're feeling about you, what you do with that. And again, I come from a relational perspective where I think the primary catalyst for change is the therapeutic relationship, which is a different theoretical orientation than other people. So that's the main focus. It's not therapy. We're not sitting and talking about your mother, we might reference that, but it's also a way to identify like who does need help as therapists, like if someone's struggling, it's getting in the way of their work. And I just think it should be an ongoing thing. I don't care if you've been doing it 50 years. I think it's a huge, huge piece of it. And here we do, we tend to get together as officially, like formally, about once a month. But informally, that's why I always had an office just me for many years. But
Hmm.
I sort of like handpick the people I share office space with. One, because people will assume an affiliation just because you share office space, even if you're not in a practice together. But also, just to be able to like touch base about cases and to share cases. Like you see the mom and I see the, the dad or something like that. And just those little interactions and ways of thinking about cases is so important to get that other feedback, because you can be so off, so off when you see someone we're stuck, and you need to be able to talk about it. It's the cases where I think I'm really on that I find I'm usually so far off, those are the ones that it's like, hey, there's your dog. Is that Wilma?
Where's Wilma? Bring her on screen.
I muted myself so that if someone's listening at home, their dogs don't start barking at my dogs. I don't know what she's barking at. Probably a squirrel. The same squirrel we see every day.
Wilma's famous on the podcast.
Charlie.
Which one? Charlie?
They're both famous. They're both podcast famous.
My cousins were here the last couple of days, and yesterday morning I got out of bed and found Charlie sleeping with one of them. And then I went back to my room to make my bed, and he was in our guest room sleeping with the other one. Mm-hmm. And then I went back there like 15 minutes later, and he was back in the other room in the first bed sleeping with my cousin. I was like, this dog gets around. Yeah. Okay, so I don't know how much time we've got left. So my one question I want to ask you, because I think this is pertinent to people watching. We're a little less addiction and substance use focused today, and a little more like therapy 101. So if someone was thinking about coming to therapy, I know that when the first couple therapists I saw, I like paid to lie to them because I didn't want them to. So
I've done that before too.
I feel like everybody has, right? Like everybody has these relationships where they like want their therapist to like them, so they lie. So what I would like you to know is like, is there stuff that you consistently see that people come in and talk to you about, and they are like convinced that no one has ever experienced it before, and you like regularly hear about it in therapy? Like traumatic histories and stuff. Like, is there something that you would want to say to someone like, you are not the only person who's felt this way? I hear about this all the time. Or is that counterproductive to say that to someone?
Let's see. I think I think everybody needs that validation. I think it could be a fine line because it could come across like, oh, everyone feels that way, like, oh yeah, a lot of people are molested, or it can be a validating experience, obviously, to say, people who have been through things that similar to you often have that experience, and that can be very validating, for people to understand that they're not crazy or weird, that in crazy or weird experiences, those are normal reactions to things, absolutely. So I think that can be incredibly validating. I feel like Trump using the same, adjectives over and over. Incredibly validating.
Now, what would you say to someone who has never really been to therapy before, maybe is thinking about going, or maybe doesn't think that there's any sort of benefit or something like that? What would you like? Do you have a lot of people that ever come in for like the first time? Like, what's that sort of like?
Absolutely. I think a lot of times if you, I think if you're working with someone, I always like to, again, this is just my approach, I always like to involve as many people as possible. I think it's great to be able to see people in a context. So, let's say someone comes in and you can tell that the issue is marital right away. You
right.
might someone in, a husband in or a wife in, kicking and screaming like they don't really want to be there. But I always say, like, let's agree to see each other twice, and I think any client or person, if you're calling a therapist, just agree to see them twice. If it's not a fit, move on. And the same for a therapist. If you have a private practice, I don't think you should take any client that walks in. If you don't like your client, like, everybody deserves to have a therapist that likes them and that feels like they can work with them.
Right.
So I think that's really important, that you feel like shop around. That doesn't mean like see someone for 6 months, fire them, see someone else for 6 months, because you don't like what they say, but you have to feel comfortable. I think you have to feel like the person is as smart or smarter than you, and that they know what they're talking about, and that you feel like you can trust them and feel comfortable with them. So I'll hear people say, what's common is, well, I was seeing this person for like 9 months, but I really wasn't comfortable. And I'm like, my God, why would you stay with that person? So I think that's a huge thing that people need to know. Like, you're not stuck with someone. And I'll tell people who don't, if like a parent mandates it, I'll say to them, don't, you don't have to see me. Therapy may be mandated, but it doesn't have to be with me.
Right.
So if you don't like me, that's fine. You can find someone else. I can even refer you to someone else, but let's meet each other twice and then decide.
How long would you say is there like a typical length that, or period of time that someone will come see you for?
It really depends on what they're coming in for.
Right.
Or, I think I probably tend to see people a little bit longer because of the kind of work I do. I do less like symptom management things, and a lot of times if I have something like that, I'll refer it to someone else, because there are just people who are much better at CBT and EMDR than I am.
Right.
It's not that I can't do it and incorporate it in, but they're just people who do it a lot better than me. So I tend to do more, deeper relational work. I do a lot of trauma work, which tends to be, at least a year or maybe a little longer, 2 years
Right.
even.
Okay. Interesting. Yeah, I don't really know anything about therapy at all. That's why I have these questions.
Maybe that's because you need to go. No, I'm just.
It's funny because I don't remember who said it to me, but years ago, I was talking about therapy and psychiatry with somebody, and we were talking about how, like, people will have a knee injury and they go to the best orthopedic surgeon in the area. They'll drive to Philly. They want to see the best orthopedic surgeon, or they have a back issue, so they go to like the best chiropractor in the area, and they ask around and they get all this feedback. But when someone goes to therapy, they're like, I'm going to Google this on the side.
Yeah,
What
exactly.
any of this means,
Right.
but okay, they do that. That's great. And like, you secretly go and you don't talk about it and you don't ask questions. So like, sometimes Gina makes fun of me because she's like, why do you just give out like your therapist's phone number and my phone number? It's like, what do you talk about with people that you're always like, take this number, call this person? But I feel like when good care exists, you just want people to know it's there,
Right. And I think someone said once, there's no such thing as a good therapist or a good client. There's just good therapy, so it comes down to that fit. I think that's important too, to remember. But I was going to say something, but it flew out. I think I was.
Okay, so
I think another thing is to ask around, and I think one of the things when I was young and early in my career, I was popular, like, especially among young people, and it was like, go to her, you'll love her, she's great, and I think clients liked me, and I'd sit back and I'm like, oh my God, I was like 28 years old, like, how was I possibly helping these people? So I think it's, to ask around, but also if you see your friends or whoever like actually changing, that's the important thing. Not just, oh, I like her, she's great. It's like, well, are you actually seeing improvements in this person? And that's much more telling, than what they, say about this person. So I think that's an important piece of it too. And to remember too, therapy is not always the answer to everything. Like, sometimes people just need to, like, find something they need to, like, work out, or they need to, there's the baby.
this is your next client.
He's got a lot of issues.
He's going to talk all about his parents.
His birth parents or his adopted?
Yes, it must be his birth parents. Yes, that's all I meant. Yeah.
Good, thank God.
How he was saved by his adoptive parents. Yeah.
Oh, you talked about that. He doesn't want to get
And it's always a good sign of a therapist they have their dog, in therapy with them. That's always a good sign.
Very good sign.
Oh, all right. Anything else? Anything we forgot?
I think it'd be good if you could tell people how, if they wanted to get in touch with you, or how to find other resources, would be a good thing.
But you don't have my name like that you can put up, like,
I will. Yeah, I'll definitely do that.
I'm on the internet. Gina Innocente, Summers Point. If you look up therapy in Summers Point, you'll see a picture of me, but it's actually about 30 pounds and 10 years ago, my picture, just because when I put it up, I get a lot more referrals. So
I recognized you in public from your picture.
barely, but I always say it's like a bad dating site. When people come in, I'm like, I'm sorry, it's like a bad Tinder thing. But give me a try anyway. So, but yeah, Summers Point, Gina Innocente, and that's me.
They'll find you.
They'll find me. Yeah.
Awesome. Well, thank you very much for taking the time to speak with us this morning.
Having me. Yeah.
You're welcome.
Appreciate it.
You're welcome. See everybody next week on the Surfside Recovery Podcast. If you need to look up Gina, look up Gina. And
just Gina, I'll pop right up.
that's it. So long, everybody.
Awesome. Bye, guys.
All right, bye guys. Thanks for having me.
Thank you, Gina. Thanks.
Bye.
Brian.
Take care. Nice meeting you, Brian.
You too. Bye.
As always, if you or someone you know is struggling, please reach out to Surfside. You can give us a call at 609-709-4205 or get us on the web at surfside.org.